Dr. Haneke, Professor Borger, thank you for this session. And also I thank the Society for giving me this privilege to present my experience in the field of endocarditis in the treatment with cryopreserved homograft. It has been since I started this studies in the 70s when I worked with Mr. Ross at the National Heart Hospital in Sir Magdi during this period, as well as also in the Harefield Hospital. And I think it's very important doing allograft surgery to know the science about this type of surgery. It's very important so that you can actually know with what you are dealing with. Endocarditis has been a very important and challenging disease in a cardiac surgery, and it began in the 60s when Wallace and Robichek introduced the surgical treatment. However, it was associated with many complications and also high mortality. And Mr. Ross introduced the use of allograft, and as well as during the period also the autograft. And Ross used the allograft for the surgical treatment in order to reduce both the high mortality as well as the recurrent endocarditis. And Oswald even also used the pulmonary autograft because, especially in children, for the potential of growth in order to have these children have a longer survival without early reoperation. So that we are dealing with going back to nature with a living tissue. It is resistant to infection, the cryopreserved allograft. It's same also a pulmonary autograft, which is also a living tissue. However, the limited availability in pediatric sizes now even supports the use of pulmonary autograft in children. The cryopreserved allografts, the coadis. In the past, we're using the homograft or the allograft at all ages with liberal indications with the exception of the Marfan's. However, presently, we are now faced with the question at which age and which patient group and what type of valve devices we are going to use for treating endocarditis. We know that the endocarditis with periannual abscess is a challenging disease where recurrent infection as well as mortality is higher as compared to endocarditis without abscess formation. And then comes also, is allograft competitive or complementary to Ross operation in selected patients? Whilst we know that reconstruction, as outlined by Dr. Halis, for reconstruction of the right ventricular outflow tract, especially in Ross operation. Also, the future will be the desolarization technology, the tissue engineering, to achieve biocompatibility and eliminate immune response. If we distinguish the operation periods over the years, we have about 3 periods where the surgical results, so far as patient survival as well as the recurrent endocarditis are concerned. If you take the early 80s, data from known where the mechanical versus bioprosthesis homograft were nearly identical, even in different type of valves groups, if operative deaths were excluded. Now, between 1980 and 1999, the mortality of prosthetic valves used for endocarditis is between 7.4 to 23.5%, with a recurrence rate of 6.5 to 27%. Allograft is 8.3 to 17%, and the recurrence of 3.6%, as compared to pulmonary autograft, 0 to 12%, and with a recurrence rate of 0 to 3%. Let me give you these comments from Tyron David, who actually said that, however, we firmly believe that radical resection of the abscess is more important than the type of valve implanted to eradicate the acute infection in these patients. However, if you consider the period 2000 to 2009 and compare the results, allografts and pulmonary autograft, you see there's a significant difference so far as allograft survival and the pulmonary autograft survival is concerned. And this gives us information about which patient group should be considered for allograft and which patient group should be considered for pulmonary autograft. The determinants of the selection and outcome are the aortic pathology, infection beyond the aortic root, concomitant procedures, and then to consider the procedure of choice, and as well as also the surgical scale. If you think in terms of the hemodynamic, you know the pulmonary annulus is naturally 2 millimeters larger than the normal aortic annulus, so that the Ross procedure provides an upsize, therefore, the most ideal hemodynamic performance as compared to other procedures. Now coming to recipient age-dependent structural valve deterioration in allografts. See that age also plays a very important role so far as reoperation is concerned. And the comments by Dr. Takelberg in one of her publications, that's age group, let's say under 55, they have the lifetime risk of reoperation for structural valve deterioration by 60 to 80%. And this is a great concern if you also think about age of recipient as well as the age of the donor. This also gives a very important information, publication by Lund and Sir Magdi's group. If you take a 30-year-old recipient with a 30-year-old donor, the actual freedom from reoperation is quite different. A 30-year-old with a 65-year-old donor has an entirely different high rate of structural valve deterioration. The same inversely also with a 70-year-old. So this gives us an impression of what to do, which patient should have what. And this is a statement from Oswald, who said, we find it difficult to replace a 20-year-old patient's valve with a homograft, because the endocarditis may be cured, but the patient will need a reoperation in 16 or 15 years' time because of homograft failure. So these are challenges we are having in order to establish an absolute indication for the use of homograft in this patient. Therefore, our data should be a data-driven decision-making rather than dogma-driven bias. So we need a science, which means better data, to make better medicine possible. And it's a very interesting publication by Sir Magdiagu's group, where they had a prospective randomized studies on cryopreserved aortic allograft versus pulmonary autograft replacement. And you can see clearly that the homografts versus the autograft have different results so far as survival is concerned, especially, and also the reinfection is concerned. And this is also a very important data because, as we know, pulmonary autograft is a living tissue for natural, whilst the pulmonary homograft is a living tissue but only in a limited time period. If we studied our cases, our data in the last 15 to 20 years, considering the 30-day survival, the incremental risk factors for death, early, late reinfection, age-dependent durability, and review the literature to compare our results. These are the pathology we've seen in all this: native prosthetic valve endocarditis, and we had about 421 patients which were under the study with my colleague who is here, Dr. Moshi, who has done a lot of this work too. Root abscess were 254, no abscess 167. we have double valve endocarditis in the series. Most of the common microorganisms were the Staphylococcus, as well as the Streptococcus and Enterococci. You can see the abscess formation was almost evenly, because these microbes are the so-called biofilm reproducing microfilms. So each of these microbes can even also develop abscess formation. The age were between 2 and 83, average 51. We had series of periannular abscesses, this is 161. So most of these results are going to concentrate on the periannular abscess formation. 18% with congestive heart failure, 21% with septic, and 6.2% with septic shock, and 5% with cardiogenic shock. Cerebral aneurysm was in 3%. And very important is that the conducting system, as well as the double valve endocarditis, also plays important role so far as the long-term results are concerned. So I would like to give you now the final our results, which would be that we had an operative surgical result. The early results was early elective and ejecting number 9.3%, emergency 14%, native valve endocarditis and prosthetic valves were significant as far as the prosthetic valve endocarditis is concerned. The early and late complications that you're seeing here, paravalvular leaks, residual VSDs, as well as the aortic right atrial fistulae. The late survival under 40 years, at 10 years was 73%, at 15 years was 64%. In patients over 41 to 60 was 53% versus 47 at 47 years. I would like to just give you some short information about the failure modes, not only the immune response as part of this, but also the implantation technical, that if you place the homografts below the annuli without properly reconstructing the left ventricular outflow, you are going to have a constriction and limits the outflow tract, which is also called supravalvular stenosis. This has to also to be avoided, as well as also choosing undersized homograft, which also could also, even if it's a root replacement, could give you postoperative early degeneration and gradients. So my last results about predictive factors for reoperation were reinfection. Preoperative abscess was not highly significant, whereas, as I just mentioned, undersized allograft was very significant so far as reoperation is concerned. So the cryopreserved allografts, COADIS, what is the place of allografts in the present day of cardiac surgery? I think that presently, endocarditis with periannular abscesses is our absolute indication. Allograft could be competitive and complementary to Ross operation in selected patients, whereas in the future, decellularized technology could probably also provide biocompatible homograft, especially in pediatric cases. So my inferences, also we have to plead for early referral by the cardiologist for better outcome, and also tutorial guidance to optimize the learning curve results. Lastly, my conclusion is that root abscess with ventricular aortic discontinuity should be favored for homograft rather than for Ross operation because of the extensive surgery involved, and also very sick patients in whom more than double valve procedures are required as a rescue procedure is warranted. So I thank you for your attention.
Thank you, Professor Janka, for giving such a comprehensive overview of this extremely complicated issue of endocarditis. Unfortunately, you showed 2 randomized controlled trials, but they're not in endocarditis patients, of course. It's a broader group. Yeah. And I guess you would need a lot of patients to find out what prosthesis would be better. Or yes. Do you believe Tyrone David, who states it does not matter what prosthesis you implant?
Well, of course, the general surgical principles of treating endocarditis is to eradicate the infection at the in situ. But the homograft or the pulmonary autograft, being a living tissue, could also resist the remaining infectious area, which couldn't be eradicated. Probably that could be the difference, especially if you compare in the autograft with the homograft. There's a vast, significant difference so far as reinfection rate is concerned, where also it means a reoperation rate is concerned, and that also reflects on the survival. So we believe that living tissue or biological tissue without any foreign material will be the perfect device for endocarditis with periannular abscess formation.
Thank you so much. Thanks. Unless there's an urgent question from the audience, I'd like to move on to the next speaker because we're running a bit late. Thank you so much, Professor Janka. The next